Now we're going to move on to our second lecture. It will be delivered by Ms. Wong, May 1. She is breast endocrine surgeon and head department of GH Penang. She will talk on routine IPTH post-total thyroidectomy. Ms. Wong, please.
Thank you, Mr. Junaidi, for the kind introduction. I'd like to thank Dr. Amy and his organizing committee to invite me to give a talk. I gave this same talk in Langkawi in 2018. So for those who have listened to it before, I want to apologize. But nevertheless, I have made a few changes and I updated a few slides. So I hope you all would bear with me. Okay, so just a short introduction. Ms. Chan has actually elaborated on this. I'll go through this very fast. So the term, this complication should be termed as hypoparathyroidism. And it's a frequent complication after total thyroidectomy. I term it frequent because a lot of us has experienced it. It's not supposed to be very common and it's not supposed to be very rare as well. Okay, hypocalcemia is just the end result because the main reason for this complication is because of injury to the parathyroid gland. So we all know this transient and permanent hypoparathyroidism, the duration of time, classically it should be 6 months, but recently there are many papers that suggest to extend this duration to 1 year, like Ms. Chan has mentioned before. So like she mentioned, the incident is very variable. Even the incident rate that she showed to us is not the same as I found also. But nevertheless, surgeon experience and expertise remain the most important factor to reduce this incident. So there are papers who quote that in tertiary endocrine centers, transient rates should be as low as 5.4% and permanent should be as low as 0.5%. So I'm not going to elaborate on the effects of the prolonged hypoparathyroidism. Okay, and as many centers term this hypocalcemia, there are so many variables like Ms. Chan has mentioned before, how to define this hypocalcemia. So I'm not going to go through this also. And but do bear in mind that injury to the parathyroid gland are not the only reason patient became hypocalcemia post-total thyroidectomy. There are many other reasons as well, such as hemodilution. Okay, when there's surgical stress, there is increase in urinary calcium excretion. Also, when those with big thyroid gland, large goiter, there will be calcitonin release. And then, and when we operate on patients with chronic hyperthyroidism like Graves' disease and Hashimoto thyroid disease, then eventually when we remove the stimulation of the thyroxine, then the patient will eventually go into a hungry bone syndrome. And surprisingly, our country actually has a high incidence of low vitamin D, despite us being in a very sunny country. So low vitamin D alone also is actually a risk factor to develop hypocalcemia after total thyroidectomy. So these are the risk factors. Okay, so I like to emphasize again the advantages and utility of IPTH as a post-operative indicator to monitor this complication. I still quote this paper because I feel that this paper is the best to compare the sensitivity of the test and the positive predictive value because it compares with the calcium slope, the one that we always classically do. We check the calcium post-op day 1, post-op day 2, and we see the trend. So IPTH, when we take on day 1 and we take along with the calcium, it has a very high sensitivity compared to the calcium slope. And when we lower down the threshold to 10 picogram per mil, then the negative predictive values also is actually higher. So I quote this, APA actually came out with this paper after our Langkawi conference. So they also encourage measuring the IPTH either intraoperatively or early post-operative intact PTH can help in managing patients with should they have this complication. So in fact, this paper also, they quote the previous study. So when would be the optimal time for sampling of this parathyroid hormone? Like Ms. Chan has mentioned before, we can do intraoperative IPTH assay. We can do it post-op day 1, we can do it at post-op day 2. But the IOPTH is, as mentioned before, is not cost effective. And actually I think all of us, most of the centers in Malaysia, we don't have this rapid PTH assay. And but the advantage is if let's say, if you have it, you can actually remedy the problems intraoperatively, like parathyroid auto-transplant. So ATA actually recommend that it is adequate to just look at the IPTH value 20 minutes and later after the surgery. So I like to share our Penang experience again. I need to give credit to 2 people for this. First is Datuk Cheong for initiating this study and making us continually follow up this study. And 2, Dr. Neo Shweli for collecting all the data and making a study of it. She's actually very good in this paper already. Anyone who knows her can ask her directly about this. So what we did was we approached the head of pathology lab regarding this, and we wanted to ask whether they can do this IPTH study routinely. So they actually agreed, because they do IPTH study once a week, and they just need to time doing the study 1 day after our surgery. So the timing is just nice lah. We started this study in August 2017. Back then in Langkawi, when I presented, we only had 43 patients. But 4 years later on, 3.5 years later on, we have managed to collect 168 patients, and out of these, 22 underwent completion thyroidectomy instead. So we found that we took the value of IPTH less than 5.5 picogram as our standard for hypoparathyroidism, and we had 11 patients who had this. 5 of them underwent central neck dissection. All these 11 patients given oral calcium, and 5 of them ended up with a long-term calcium supplement. But surprisingly, only 1 biochemically has prolonged hypoparathyroidism, meaning that the IPTH remained low even 1 year after the surgery. So we don't have many patients given IV calcium, only 6 of them, and most of them are given only 1 day. Day 1 after the surgery, and after that we just convert straight to oral calcium. So in our center, our incidence of transient hypoparathyroidism is 6.5%, and permanent hypoparathyroidism is 0.6%, which I can happily say that it correlates with the general papers lah. So now I like to mention about cost, because a lot of people worry about the cost. The cost of doing the IPTH study alone is 73 ringgit. And we always take IPTH together with calcium and albumin, all this together post-op day 1, so it costs around 100 ringgit. But yes, oral calcium is very cheap. Calcitriol also is very cheap, but the moment you start IV calcium gluconate, it actually offsets whatever that the IPTH cost and the albumin and calcium cost. So I just like to highlight that. And there are several issues that I also want to mention regarding treating transient hypocalcemia after thyroidectomy. And 97% patient would have some decrease in serum calcium post-op day 1. And we observed that in our center as well. So, the throw level, the lowest that it can go is actually at post-op day 2. So we have to keep the patient for more, if you just monitor the serum calcium until post-op day 2 and after. And there are many papers that mention that prophylactic treatment with oral calcium and calcitriol to prevent this incident is actually cheap, cost-effective, and also effective. But the thing is, when we do this, it's very difficult to identify who truly has hypoparathyroidism and who does not. So it's very difficult to collect data about this incident. And once you start calcium and calcitriol, when do you want to stop it? And as I had to be frank, most of us, the patients, post-operatively, they are followed up in the clinic by junior doctors. And most of the junior doctors will just continue giving the patient calcium and a calcitriol supplement until forever. Okay, so but at the end of the day, does every patient post-thyroidectomy require calcium treatment? So I quote this paper because the surgery that the patients underwent are all that we do. Pretty much the same as we do in our centers. So all the patients exhibit some post-op decline in calcium, but surprisingly, only 0.13% require calcium supplement. So they conclude that if the calcium replacement is not needed in the first 3 days of the surgery, probably it's not going to be needed. So I receive a lot of questions how to manage patient when you start this IPTH study. So I put up this paper. Some centers have actually put this algorithm. It actually closely follow to whatever that we are doing. But for us in Penang, our threshold for starting calcium is actually rather low. We start it when the calcium is less than 15, or less than 5, or if the calcium is serum calcium is less than normal, and also if the patient exhibit symptoms of hypocalcemia like a positive shock test sign, or if they complain of some paresthesia. So IPTH also has come up with a guideline on how to manage, and they also mentioned that if the patient only has mild symptoms, or even if it's progressive, when the IPTH level is less than 15, you can just start the patient on oral calcium. There's no need to start calcium gluconate unless the patient is symptomatic or severe. So in summary, for me, routine IPTH after total or completion thyroidectomy should be employed as the new standard of care at all endocrine surgery centers. It is actually cost effective if you count all the hidden costs, okay. It also facilitates audit or any study concerning post-operative thyroidectomy complication. So whoever is still thinking of some study or some study, you can actually consider doing this, okay. And personally, actually, I would recommend this to be our next KPI standard for all endocrine surgery centers. So with that, I end my talk. One of the people using IPTH as a study. Okay, so thank you very much.
Any question from the floor? Probably you can raise your hand and then we'll invite you to
Okay.
the stage.
Mr. Chia has actually asked for temporary hypoparathyroidism. When do you repeat parathyroid hormone assay to determine recovery of function? So Mr. Chia is in our center. He should know. But anyway, in Penang, what we do is we repeat 1 month, because most of the recovery of parathyroid function occurs after 1 month, within 1 month. And after that, if the parathyroid level is still low, then we repeat at 3 months, and then 6 months, 6 monthly afterwards. Next question. Oh, Miss Anna.
Hi.
Hi, Miss.
Hi.
Good morning.
I think both you and Chan's presentation very good. I think especially for the general surgeon, because we have general surgeon attendees here.
Yeah,
Because when you talk about post thyroidectomy complication, it definitely based on experience and hands lah. Whoever the person is. How come no
agreed. Yeah.
my picture is not appeared? No
Uh,
photo, no video. Okay, never
no
mind.
video, only.
I on it. I allow it. Actually, I allow it to be on. Okay, never mind. Um, okay, I think it's very popular topic. I think most of our trainees would want to do this kind of research,
Yeah,
post-operative hypocalcemia. In fact, one of the master students also did this study. I think Prof. Chan also remembered this.
yep, yep.
She can did. Okay, to do a routine IPTH as you recommend, actually is a good recommendation, but you must bear in mind not all hospitals equipped with a good facility to do parathyroid.
Yeah, I agree. But but um but most of the endocrine centers that has endocrinology and endocrine surgeon would have this facility, I think. So it's just a matter of negotiating with them. Good morning, Prof. Sharon.
Ya, Mewan.
Yes, yes.
Boleh dengar ke? Can you hear me?
Yes, yes. I can hear you.
Alright.
I can see you also.
Okay. In my experience, if we do a total thyroidectomy for toxic goiters,
Yep.
patient will definitely develop hypocalcemia
Yeah.
because despite good parathyroid gland preservation.
Yes, yes.
So, what is your experience on that?
We actually have a few patients who develop hypocalcemia anyway after operating on patients with Graves' disease. And but we waited for the IPTH level and it turned out to be normal. But nevertheless, we started the patient on oral calcium anyway. Then later on during the follow-up, then we just stopped the patient on the oral calcium. Because we still believe that this is due to the hungry bone syndrome, especially for patients after Graves, operated for Graves' disease. Toxic goiter, not so much.
But you still do IOPTH for these patients.
We still check the IPTH after this patient. Every patient post total thyroidectomy and completion thyroidectomy, we check their IPTH day one after the surgery.
And one more thing, did you do a cost analysis study for your IOPTH? Cost effective study.
It's very difficult for, I really tried, but it's very difficult for me to do this cost analysis unless I compare it with another center, because when I try to retrospectively look back at the data of our own center for managing hypocalcemia without the IPTH, I don't have many, so it's difficult for me unless I compare it with another center that does this. Yeah. So which is why I can only quote the one-off value of the
you
IPTH.
can do you can compare retrospective data from from the cohort of patients that you have done without IOPTH, because the technique is still the same.
I tried, but I really don't have the value. Most of the patient before 2017, somehow I can't trace them, and then the patients somehow they all discharge fast. Maybe Dato' Chong did a very good surgery. Most of the patient doesn't end up with hypocalcemia, so that's the thing.
Okay.
Yeah. Thank you, Prof. So the next question is by Miss Leong. Do you do IO? Yes, I do IPTH level. No, I don't do pre-operatively. I just do post-operatively. It's not to me. I think it's not cost effective if you check the pre-op levels of IPTH. Mr. ID is asking, do you keep patient until day 3 to see their calcium level post-thyroidectomy? Okay, so in Penang, we actually check the duration of hospital stay for all patients, and surprisingly, most of them they stay up to 6 days for the drain, for management of drain. But after day 1, if the IPTH is normal and the calcium is normal, I do not check anymore. I don't check the calcium level anymore, and I don't start them on any calcium supplement. and all of them remain well. Mr. Raffles is asking, with an incidence of hypoparathyroidism of less than 6% in center, is it justified to do a routine IPTH? The utility of doing a routine IPTH is one enable to guide us how to manage the patient, and two is also as a we actually put it as our own department KPI, because when we do surgery, every time we do a total thyroidectomy, we really do keep in mind to keep the parathyroid glands intact. So like what Ms. Chan has emphasized before this, good surgery, meticulous dissection is actually the mainstay of preserving the parathyroid gland and avoiding this complication. So to me, I think it's justified lah. My own personal opinion. So Datuk Amy said, oh, thank you very much. Thank you very much. Yeah. Good morning, Miss Aina. Yes.
Suddenly I got disconnected just now. Very sorry.
Yeah.
Okay. Right. I was saying just now.
Yes.
We can adopt your proposal as part of our routine thing. Maybe we can form a small working group to form something like a guideline.
Sure.
Working committee of a guideline. Maybe we can discuss this after this. It's something that we can project it. A guideline that can be adopted to all BNE centers, and even for the general surgeon who want to do it on their setting. So we have some kind of a standardized kind of, because some people will do it like 6 hours, 4 hours, or maybe
agree.
that kind of things, isn't it? So I think we come up with all the referral, and we can proceed from this BF. After this, we can get one of you, maybe you or another surgeon, to sit down and select few other members to come up just as a guideline, our own internal thing.
Yeah, we should invite Dato' as well because he's
of course.
He's the one who started this and overlooked for all this study.
Yeah. He's good actually.
Because
this issue of cost effectiveness, people say IPTH, what? IPTH, I mean IPTH say people get scared already.
Yes. But a lot of them they don't.
Yeah, what Chan mentioned earlier in her earlier lecture, if you do it on a planned manner, rather than being reactive or jerky manner, I think in the long run it will be more cost effective rather than you have a patient with keep repeating doing calcium, IV calcium, that kind of thing. Okay, something to be take home message for the rest of us. We can form a proper a solution and a guideline for this.
Right. Thank you very much, Ms. Aina.
Yes, Wong, I just want to comment. It's a good talk. It's a good lecture given by you just now. And I should congratulate you with Penang Center for very minimal amount of complication hypocalcemia post-operatively, about 6% only.
Yeah, thank you very much.
All right, and then I agree with Ms. Aina. Maybe we should sit down and we should discuss on how to improve the condition in all the centers in terms of using IPTH level post-operatively. So maybe we can use this platform to discuss after this, maybe after our conference. Okay?
All right, thank you very much.
Get it published, Wong. Please get it published.
Oh, yes. We actually wrote the paper. It's just looking which journal to. Yeah, all right, okay.
Well done.
All right, thank you.
Okay.
So, do I need to answer more questions? Okay. So, Mr. Nick has asked, can you describe on the use of hydrochlorothiazide with patient with hypocalcemia? When do you consider to add it? Okay. In the ETA guideline, they actually recommend adding hydrochlorothiazide for patients with refractory hypocalcemia after post-total thyroidectomy. Usually, you can consider adding this if the patient has been having hypocalcemia more than 1 year, is already considered permanent, and has histories of admission to the ward, many times requiring IV calcium gluconate. So if you have those kind of patients, and the dosage of the oral calcium and the vitamin D has maxed out, means that you probably need to consider giving hydrochlorothiazide for this kind of patients. Maybe Prof. Sharon want to add something for this?
No, I don't have anything to add about hydrochlorothiazide. Okay,
Yeah.
but one thing I want to add is in patients with hypocalcemia post-total thyroidectomy, I have come across one case whereby this patient is total, even we load her with calciums, the calcium doesn't goes up. And when we check the calcium, when we check the parathyroid hormones, the parathyroid hormone is actually normal. No, it's low normal. But it's not, doesn't say why the calcium is low. So we check, we call the endocrine, and then we discuss, and then we check the magnesium level. The magnesium level is low, is very, very, very low. And we look through the literatures, yes, magnesium do have effects on the parathyroid gland function. So that is the reason why I think we have we have put it as an article in IMJM last 2-3 months, whereby hypocalcemia secondary to low magnesium.
In fact, there are a few papers that mention of this similar incident, just that I didn't put up.
Okay.
Yeah.
Thank you very much, Ms. Wong, for very informative talk and a good suggestion for us. We're working on that.
Okay.
So
Thank you very much.
we will have a break. Okay. We will have a tea break for a while. We come back at around 10:40.
All right. Thank you very much.
And then while you are having break, probably you can have a chit chat or ice breaking in the social lounge. Okay. See
all
you.
right.
Bye.
Thank you very much. Thank you.